Do a slide like this, sir. Once I finish your introduction, then you speak, sir.
Yes.
Good evening, everyone. I, on behalf of Takeda, welcome you all and thank you for taking out time to attend this webinar. Let me introduce our speaker for today, Dr. Arun. Dr. N. Arun needs no introduction. We have seen him before on this platform. He is currently consultant gastroenterologist, hepatologist, and interventional endoscopist at Apollo Hospital. Thank you for taking out time to attend this webinar. Let me introduce our speaker for today, Dr. Arun. Dr. N. Arun in today's webinar, Dr. Arun will share his insights from various clinical studies and experience on targets to treat an IBD. If there are any questions, you can use the chat box. And if once you post your questions, we will address it to the speaker and he will attend to the questions in the end of the session. Sir, Dr. Arun, can you please start now, sir? Thank you.
Yeah, very good evening, Team Takeda. Gave me an opportunity in this wonderful evening to discuss on one of the most complex entity in the field of gastroenterology. Even with multiple discussions, multiple events, still we need more and more trials, we need more and more papers to find the best of solution, what's happening to tackle this inflammatory bowel disease. As you all know, if there is any chronic inflammatory condition, if it is going to set up in your GI tract, that will be predisposing to your IBD. Two major entities in your IBD. One is because of your Crohn's and one is because of your UC. The basic outline, as you're well aware, the basic thing is you need to identify which condition you're going to target first, where the lesion predominantly located, in which segment of the GI tract been involved, followed by how you're going to initiate the patient, starting from your basic line of management and up to the advanced protocols. What are the things if you're planning to consider? And today, our area of interest to talk on one particular molecule called vedolizumab in targeting the therapy to look for your inflammatory bowel disease. And as per my experience, we have been used for more than 5 patients with vedolizumab support as of now. But how the patient responding, even by tomorrow, I'll be looking into the patient's clinical scenario to a patient with evidence of Crohn's. And he just completed 18 years old. He presented to us with a long-standing presentation for more than 6 months to 1 year, been treated in multiple centers outside, and followed by the patient at this kind of event, and he presented to our center with worsening of manifestations. Why I would like to point out this, so what is the region, what's the area going to target, what's the line of molecule you're going to use, how are you going to analyze the clinical scenario, all this picture one day won't be enough to talk on that. Your clinical experience should matter a lot. How are you going to tackle this? And serial follow-up, serial monitoring, this is what is needed to look for the response. Your inflammatory markers, starting from your CRP, ESR, your calprotectin, your albumin levels, all those pointers is important to consider when you're going to target your treatment. And first, always, this is the basic disclaimer slide. And what is there to look for your treat to target goals? One is immediate response. The second one is intermediate phase of response. And third one is what is you're going to do in long term. If you're going to look into vedolizumab, you are going to use 300 milligrams at 0 to 6 and followed by every 8-weekly interval. If you're going to give intravenous regimen or a duration of time, how are you going to assess the patient response? As you all know, there are 3 major components of molecules in tackling your monoclonal antibodies. One is humanized preparation, another one is human-based preparation, and another one is chimeric preparation. The chimeric one, well aware, your infliximab and other molecules, and your human-based preparation based upon your adalimumab, and humanized your based upon your vedolizumab and other things. So how are you going to tackle this alpha-4 beta integrins pathway, which is having a separate attraction towards a molecule, what is called as MATCAM presentation, in which you are going to tackle your lymphocytic response. That's the area to tackle your inflammatory bowel disease, to address this cascade. And there are so many other new analyzing molecules being in pipeline to look for this therapy. But how are you going to tackle this is very, very important when you're going to look for this presentation. And clinical response, the patient symptoms has to come down, the pain has to reduce, the stool frequency has to reduce, the bleeding manifestations has to come down, the nutrition status has to improve. That's what the clinical response, the quality of life, how you're going to respond is in long term. Endoscopic healing as well as the disability, the abstinence to school, abstinence to college, the disability has to improve. Apart from that, the intermediate presentation will be your remission. The patient needs to maintain a proper remission, which means the stool, the CDIS scoring, the ulcerative severity index scoring has to come down. The patient with lower dose of medications has to get maintained. That's how the clinical remission is going to get attained over a duration of time. And normalization of your CRP to level less than 6, that's very, very important when you're going to target on intermediate cascade. So the focus of treatment in IBD has shifted from symptom treatment to healing and long-term impact, mainly by we need to target on symptom control, but during the period of disease course. And apart from that, endoscopic remission in ulcerative colitis is very important because you see serial follow-up, the patient risk of progression to cancer will be in the higher phase always. So we need to prevent the evidence of colorectal carcinoma. Apart from that, endoscopic healing, that's very important. See, we have been seeing multiple patients starting from infliximab and adalimumab, and slowly when you're going to look into other molecules. And so far, we have been seeing some patients who have been not responding to any molecule. So those kind of patients, how are you going to analyze what are the next line of therapy which is available in India? All these pointers is still need more. The financial constraint, the efficacy, the prevention of complications. And one good thing about vedolizumab, it will not cross your blood-brain barrier much, and it will be having a prevention of progressive multifocal leukoencephalopathy effects, which may get happen with your nadalizumab and other molecules. It's very safe to concern when you're going to look into this potential adverse events to get prevent when you're going to use your vedolizumab over a period of time. Apart from that, so this is what the basic strategy, choosing the molecule and preventing opportunistic infections, the cost efficacy, serial follow-up, all these things to get addressed when you're going to choose your biologics to your patient. And the most important thing is you need to propose a proper algorithm for UC. This is what the strike strategy, strike position statement, what they're going to mention in this. So first is your symptomatic response, and next one is your normalization of CRP, and next one is your calprotectin has to come down, and your endoscopic healing has to get attained. So this is what, based upon your histological healing, that's what the target has to get maintained. The short-term benefits, mainly based upon your basic response, intermediate and long-term targets. This is how the schematic representation, and you're going to target your ulcerative colitis. Regarding this proportional, when you're going to see your Crohn's, the basic symptomatic response is your short-term target. As I discussed, your normalization of CRP, and you need to maintain the growth chart. The growth of children, the failure to thrive is a very common scenario in your inflammatory bowel disease cascade. That too in the background of Crohn's, in which the small bowel lesions will be more prevalent. And at that kind of time, we need to be very cautious in documenting the growth chart to the pediatric population. And decreasing calprotectin and normalization of the growth is one of the most important target when you're going to look in intermediate focus. And over a period of time, a good endoscopic healing along with your quality of life has to be significantly improved with a proper disability has to come down. So this is how we are going to target with a significant transmural healing has to get attained when you're going to think in favor of your Crohn's disease, and your histological healing has to be in favor when you're thinking in terms of your ulcerative colitis. So the treatment goals, this is what the treatment goals. If you're going to look, so all the bottom scenario for your rectal presentation, anorectal complications, for starting from your stricture, your complex fistula, your abscess formation, your surgical strictures, all ileal stricture, all the complications, how are you going to address? Over a period of early disease and late disease, the structurizing components are very high. The perianal fistula, these kind of patients, you need to be cautious, and moreover, surgical intervention will be very complicated scenario. If the patient is fistulizing lesion of the patient abscess, or at the point, the ceton placement, the ceton drainage can be tried, followed by you need to give a proper biologics along with strict infection control has to be attained. with the proper antibiotic support, a good nutritious care, all those things you need to take care to prevent further worsening of complications, rather than simply subjecting the patient with surgical intervention that will lead you to further complicated scenario. Always surgery in IBD, you need to be very cautious to whom you are going to subject. That too, when the patient having presentation in favor of perianal lesions, you need to be very cautious to report the patient for before surgical intervention. Apart from that, if there is no symptoms, no inflammatory symptoms being stabilized, no disease progression complications, and normal quality of life, all these things in late phase, and this is what you are supposed to get maintained, and the symptomatic remission may not be achievable in late phase of disease. Mucosal healing as a treatment goal may be difficult to achieve in patients. If you are going to diagnose late in disease, who are already experienced a disease complication. So this is what we need to target when you're going to address a molecule in therapy. So what is the role of your vedolizumab in your inflammatory bowel? So 3 markers, your CRP, ESR, calprotectin, all those things you need to look. This CRP, it's nothing but your acute phase reactant, which is predominantly be involving the liver. And it's one thing, if you're going to look into your various polymorphisms within the various regions of your CRP gene, which may affect baseline of stimulated CRP production. So 25% of the population with demonstrable activity of your CD on endoscopy do not express CRP above the normal threshold limit. That's what being the mentioned cutoff as per the guidelines which has been mentioned. And your fecal calprotectin in your Crohn's. So fecal calprotectin, it's predominantly which has been derived from your neutrophilic granulocyte. It has shows of high specificity and sensitivity, almost in the range of 90%, and non-invasive tool and marker, a significant marker for your biochemical as well as your mucosal activity, predominantly in your CD. And so the greater reduction of your CRP and fecal calprotectin will get happen when you're going to use your vedolizumab when compared to your adalimumab. If you're going to look into the armamentarium, how are you going to start the treatment with adalimumab? Start with 160 milligrams, that means 4 vials bolus, and give the patient every 2 weekly interval, which means initial phase 80 milligrams to be tapered after 15 days, and after that 40 milligrams to be maintained every fortnightly. That's what whenever you're going to use your adalimumab support. But vedolizumab, as I already discussed, you need to maintain at a target of 300, 0 to 6, and then maintain at 8 weekly interval with your vedolizumab. And you're going to look into various trials or papers. The best one, your Gemini trial, what they mentioned in this, you need to consider how you're going to use your vedolizumab when you're going to use in the consideration. And apart from that, the most important thing when you're going to compare these two limbs with your vedolizumab as well as your adalimumab, so what's going to happen? Your CRP concentration at baseline will be having significant impact with your vedolizumab, and along with your calprotectin also will be having a significant impact rather than your adalimumab alone. So always vedolizumab is one of the potential molecules to consider when compared to your adalimumab at week 14. That's what being the paper we mentioned, and to consider in the armamentarium of management protocols. Apart from that, your vedolizumab will be achieving a meaningful response at just a minute. At week 6 to improve your inflammatory marker during the induction period. So what you're going to see, your CDAI scoring at week 26, your CRP concentration at week 26, at fecal calprotectin. So what you're going to see, that will be having a significant response, achieving a target scoring of CDAI with your CRP as coming down and fecal calprotectin levels is going down over a period of time when you're going to use. That's what being considered a meaningful, significant clinical response at week 6 being mentioned in this paper, which has been proven in various trials. Apart from that, endoscopic healing. 2 major scoring system, your Trulovitz scoring as well as your Mayo scoring system for your ulcerative colitis, your CDI index for your Crohn's disease activity findings. All these pointers you need to see, you need to take into account. And endoscopic healing as well as your histological response, that's very important. Why mucosal healing is very important? Because We need to look for steroid-sparing effects, the lower relapse rate, fewer hospitalization, and quality of life will be significantly improved, and reduction of your CRC, colorectal malignancy risk, and the mucosal lesion predict relapse after anti-TNF withdrawal. So anti-TNF withdrawal, the mucosal lesions, if still there, that might be having a predictive response that the patient may have a significant impact during the course of time. Apart from that, vedolizumab achieved significant endoscopic improvement uh, versus placebo at 1 year. That's what being shown in your Gemini trial. So when compared to your placebo, you're going to use your vedolizumab that shows a significant potential in this limb. So when compared to your placebo molecule, the endoscopic healing at week 52 in week 6, vedolizumab response has been tried in your Gemini phase, being proven strongly that the endoscopic mucosal healing. So within 2 to 3 doses regimen that shows a significant response, you can able to attain with your vedolizumab in endoscopic healing, also in the initial phase of therapy. Apart from that, superior endoscopic improvement with vedolizumab versus adalimumab in overall and anti-TNF naive patients at 1 year. So this is what we have tried. See, if you're going to see in anti-TNF naive patients, when you're going to use your vedolizumab, the key endpoint, the secondary point is the anti-TNF naive when compared to the potential molecule with your vedolizumab, the anti-TNF exposure affiliate shows the potential molecule. So why these papers are very important, how the mucosal response is going to get added, and how the endoscopic healing is going to get improved when compared to your anti-TNF based regimen and when compared to your alpha-4 beta integrin pathway targeting vedolizumab. That's how you need to consider the molecule to attain a significant potential response. And regarding histological healing is associated with favorable clinical outcomes and the reduction of risk of relapse as well as colon cancer in UC patients. So most important is the histological healing and remission will be having more likely to be more symptom-free, reduce relapse risk and reduce rate of hospitalization, and reduce the colorectal cancer in most of the patient, and long-term clinical, endoscopic, and histological remission need to get maintained, which will favor a probable significant disease improvement. So if you're going to use a molecule over the initial period of time, the patient shows a response, and once a patient have a relapse, so always you need to be very cautious whether to continue the same molecule or we are going to switch on to another biologics, whether the patient is going to switch on to another biologist, how are you going to titrate the dose, and all these things you need to be very cautious. Addressing the infections also as a whole is very important when you're going to tackle a patient with inflammatory bowel disease. Apart from that, as per your eco statement, what they will mention in your histopathological guidelines for EC, UC, the main important thing is there are 8 pointers that have been taken into account. So main pointer will be histological remission. You need to give significant importance in UC. The reduction of your hospitalization rate has to get maintained, and higher complications rate has to get prevented, and mucosal healing has to be significantly improved when you're going to use histological remission scoring, and microscopic activity can be seen in endoscopically quiescent phase of UC. That's very important to look into an account. And apart from that, add extra information about your endoscopy, your Mayo scoring as what have been discussed, your Mayo 0 as well as Mayo 1 UC. The microscopic activity will be taken into account, and the histological activity in UC patients in endoscopic remission is associated with a lower risk of disease relapse and sustained disease remission. That's what 1.6, the pointer has been mentioned. And in 1.7, the absence of microscopic activity in UC predicts a lower relapse rate, lower hospitalization, and lower corticosteroid use and chance of developing IBD-related neoplasia. So absence of microscopic activity will be taken as a significant potential indicator to be considered. And there is absence of evidence on whether histological activity in UC in patients in endoscopic remission has an impact on future need for treatment escalation on biological therapy to be considered. So histological remission, your microscopic activity, the quiescent phases to get improved, and the targeting the patient in proper way, that's very important when you're going to address whether the molecule is going to get response, showing the histological remission attainment is there or not. That's very important to get considered. Vedolizumab was superior to adalimumab in achieving minimal histological activity, minimal histologic disease activity at week 5-2. So if you're going to look into this graph, what they'll be mentioning is that, see, your adalimumab will be having a significant, your vedolizumab will be having a significant potential response for your Gerber's index as well as your RHS scoring system, what they're going to use. Apart from, you need to analyze how you're going to assess the response for the patient and achieving a minimal histological active disease activity at week 5-2. Apart from, vedolizumab was superior to adalimumab in achieving histological remission at week. This is what? The same thing in week 5-2 in achieving a significant histological remission that's been proven in your various indices that's been mentioned. So when compared to your anti-TNF, your anti-TNF exposure of failure patients and naive patients, all these things you need to consider this as a strong potential response when you're going to consider. Apart from the basic outline about your CD, will be having a Crohn's, will be having a transmural environment. So always it's a, cicatrizing lesions, and moreover scarring lesions. The patient will be having, based upon your Montreal scoring, will be having multiple presentation. And the transmural inflammation leads to thickening of your bowel wall with significant narrowing of the lumen. So these two things, deep ulcers, strictures, fistula, abscess, all these things to be properly addressed when you're going to give a proper healing, which may establish properly with your biologic support. And should transmural healing be included to treat, including the guidelines to look for pre to target strategy. And without surgery, in this paper, what they mentioned, without surgery, without hospital admission, without therapy escalation, the transmural healing, the mucosal healing, no healing. What they were mentioning in that, so the complete healing of all the bowel layers can be measured by your MRE, your elastomagnetic resonance based technique, and your endoscopy is associated with your improved long-term outcomes. So in this paper, what you're going to see, the relapse without surgery and you without hospital admission, without therapy escalation, the rate of healing and the mucosal healing and no healing be looked into an account when you're going to treat a patient. And vedolizumab induced radiological remission in refractory CD patients as assessed by your MRE. So main thing is you're going to respond, your radiological response by your MRE, manual response elasto, when you're going to see, when compared to your anti-TNF naive, your vedolizumab will be having a potential response. That's what you're going to look into NACON when you're going to give a target to this kind of regimen. Apart from that, when you're going to use your transmural, vedolizumab was associated with a significant reduction in your lymph nodal encasement. So if you're going to look into this graph, the volume of the right lower quadrant showing prominent enlarged lymph nodes in association with your terminal ileum with increased wall thickness. So if you're going to see over a period of time, when you're going to tackle the patient with the vedolizumab support, the change in percentage of your ileocolonic segments with enlarged lymph nodes is going to significantly come down at this kind of rate. So that shows a significant impact that how the patient is going to respond to your vedolizumab. So these are all the various trial papers I would like to point out. But choosing, before concluding, how are you going to choose a patient for biologics? To whom you are going to choose a patient for biologics? Corticosteroid abuses, corticosteroid dependent and corticosteroid failure, and relapse. All these things you need to take into account. And if the patient is having acute severe presentation, the treatment protocol will be entirely different. And once a patient is going to land up with your mesalazine failure, your steroid, and combination molecules, whether you're going to use your Inflexi. We have been trying some patient with acute severe ulcerative colitis. In order to prevent colectomy, we have experienced to give a patient with Inflexi with your cyclosporine at a rate of 2 milligrams per kg. At that point of initiation of therapy, over a period of time, followed by the maintenance at around 90 days of therapy, that shows a significant improvement rate with your colectomy prevention risk and your significant response will get attained. So these are all the combination therapies to be considered. And vedolizumab, we need more papers to look into the validation. But considering this and compared to your ustekinumab in the higher range of molecule, so you can use safely your vedali and that having a significant impact in endoscopic remission, histological remission, as well as clinical remission, and maintaining a proper treat-to-target approach. That's what being considered. This is what the basic outline of all the papers being looked into that, which has been shown when you're comparing with your adalimumab in your HAC trial, and when you're comparing your infliximab in your SHARP and other trials, and when you're comparing your Gemini trials in your vedolizumab, as well as so many other newer trials for your golimumab, other molecules. So the most important thing is, the most important event is a significant remission has to get attained, has to be properly respond, clinical therapy has to get maintained. That's what the most potential target when you're going to use your biologics, and prevention of serious complications, proper vaccination guidelines to be enhanced. That's what is very important when you're going to look into the significant response. With this, I'm happy to rest my presentation briefly, and any questions over there, you can join in this discussion. And this one more thing, how does vedolizumab impact, having a significant impact in the quality of life? So in this paper, if you're going to see what they've been mentioning in that, the quality of life for the period of time will be having a significant response with the vedolizumab rather than with the adalimumab support. So this is what your frequency, your severity, your quality will be having a significant response. And in this paper also, they have mentioned the higher rate of quality of life is going to get attained, and when you're going to use the continuous vedolizumab support. And this is what the basic analysis, what they were mentioned based upon your Gemini phase trials, the chain of failure. So with the continuous vedolizumab support, how are you going to have a significant potential response to maintain a high rate of quality of life? So regarding quality of life, endoscopic severity, mucosal healing, and histological response, clinical response, all those pointers have a significant response based upon your Gemini and other protocols, your Octave and other trials, what we mentioned. So vedolizumab definitely being considered in the armamentarium to tackle a patient with inflammatory bowel disease, particularly in the management of your UC as well as your Crohn's. With this, I'm happy to rest my presentation. Thank you very much for patient listening.
We received a few questions.
Yeah.
I'll share them on the Zoom chat, sir. Can you check?
So how long we need to continue or shift or taper the therapy if the patient is showing good response over a biologics? See, ideally it depends upon that is, if, for example, if you're going to use adalimumab, there are no strict guidelines to taper the patient on therapy. But what are the ways of the papers, what we mentioned, at least for a duration of 2 years, you need to consider the biologics before you're going to stop. And when you're going to see your endoscopic attainment, good remission response, you're not supposed to switch over the biologics to whomever, whatever the criteria you're going to use. Always you need to continue the biologic support. And in case if the patient over a duration, for example, when you're going to use your vedolizumab, within 3 to 4 doses regimen, if the clinical significant response or not get attained, so that's one of the criteria to be considered to look whether the potency is still there or not. With minimal clinical response means not based upon your histological emission, and your endoscopic response with mucosal healing to some extent with your 3 to 4 doses and maximum 2 months of therapy, you need to have a significant response that has to maintain. And apart from that, when you're going to see your adalimumab, even for a duration of time, some patients may have a clinical worsening of events. That's also to be significantly addressed, and we need to see whether the patient is responding to the treatment over. So that's what the guidelines. So initiation with 160, 80, 40 over a period of time when you're going to use with your adali or vedali, so vedolizumab. So you need to see whether the endoscopic response, usually at a rate at around 4th to 5th dose, the patient should have a clinical response. Can a biologic therapy be complementary with the conventional treatment during induction? Directly as a name, you can use, depends upon the severity, a biologic therapy being complemented. But as per the guidelines, your eco-portion statement, Your biologics, once you're going to initiate, what's if the patient is having pancolitic presentation, very significant perianal lesions and other presentation, if the patient is having multiple complications, at that point, you're going to start the patient on biologic support. There is no much of role to consider the patient on other molecules. That's what I told in the initial presentation, that when you're going to use means, you can consider what else? Inflexive with cyclo, and there are some papers being tried with the methotrexate, and there are some papers to being tried with Chachak, and there are some papers with all these things being there to look for the graph. But predominantly as a monotherapy, you need to consider. That's the efficacy of vedolizumab, halter if used after any other biologic agents. Ideally, when you're going to use your vedolizumab as a first initial naive patient, there are some papers. We have seen some patients who have been directly using with CVAOC and other presentation directly with your ustekinumab other molecules. So all these things, why I would like to point out this, when you're going to use efficacy, if you see at a dose of 5 to 6 doses of regimen, the patient not showing significant response, and that's the efficacy of vedolizumab. Archer means if any biologic previously, if you're going to use, you should not use the same combination. For example, humanized, chimeric, or human-based therapy. So ideally, you need to switch on to, if the chimeric molecule is not functioning, you can go for humanized molecules like your Vedali, or you can go for human-based therapy like your Adali. So that's what the regimen been mentioned. But rather than going for the same things, it's better to choose on some other molecules. That's what's very, very important. And any role of probiotics? Probiotics, no significant potential role in IBD, but regarding your lactobacillus rhamnosus, your KSI, your GG, there are some papers showing evidence of add-on potential effects with minimal endoscopic response. Not only for that, your turmeric and other things being considered, but these are all the areas not significantly responding. And the most important thing, you should know that your gut microbiota will be taking as a separate entire system over your GI tract. So the alteration of your gut microbiota will be predisposing to your inflammatory cascade. That's how your role of probiotics definitely you can consider in the management of your inflammatory bowel disease, but probiotics alone to consider is significantly not improving to maintain a significant eubiosis when compared to your dysbiosis, what's going to happen in your inflammatory bowel disease cascade. Is there any other questions to take on?
No more questions.
Very importantly, inflammatory bowel, based upon your clinical experience, you need to tackle. Addressing the patient as a whole is very important. Look for the multiple complications and always assess the patient as a whole and see the patient's lesion, coexisting presentation, multiple other system complications, starting from head to foot, you need to see properly. Starting from your CNS, your oral cavity, your hospital lesions, starting from your other associated extra GI manifestations like your cardiac, your respiratory, your GI pathologies, apart from your genital involvement, all those things, multiple ortho presentations, your spondylitic changes, all the dermatological lesions, and your extra neurological complications, all those pointers to be considered. Complications rate is still in the higher side. Thromboembolic complications will be higher side. And using the patient as thromboembolic prophylaxis in IBD is also important guidelines. See, this is all the basic area to consider when you're going to manage a patient with inflammatory bowel disease, rather than just choosing a molecule with biologics, not a major indicator. We need to see the patient as a whole. Tackling the patient as a whole is very important when you're going to address.
Sir, we got one more question, sir. Can you have a look at that, sir? Just received. On the chat, you'll see.
I'll see.
Shall I send again, sir?
Yeah. Why is it people staying in Kerala more prone for inflammatory bowel disease? Anything to do with tapioca consumption? That might be assumption, but as of now, the proven evidence of your tapioca mainly for your fibrofatty liver, fibrofatty pancreatic focus. Apart from that, when you're going to look for your tapioca, because it might be having a potential worsening pro-oxidative, pro-atherogenic effects that might be worsening your inflammatory cascade. So tapioca may be having evidence to consider that a role of inflammatory bowel disease to go into because it's a chronic pathology, not only any chronic segments, the role of tapioca, you will be having a worsening of even. But isolated tapioca abuse cannot be taken into account, but you need to look for other things also when you're going to consider, when you're looking into the etiological, semiological presentation from Kerala, how the events are going to represent.
Sir, no more questions. Thank you so much for your time.
Yeah.
And good evening to all the attendees for attending this session, sir. Good night, everyone, sir. I'm ending the webinar now, sir.
Thank you very much. Fantastic.